Well, I would be debating on this first-line therapy in left-sided CA metastatic CA colon, RAS and BRAF wild-type cancer, and I would be debating that anti-EGFR therapy should be used when we are using the first-line chemotherapy as an adjunct to chemotherapy, and I would be debating and my opponent is my teacher. Dr. Biswajit has been my teacher, so greetings to him. So the flow of my talk is the initial trials with anti-EGFR therapy, understanding the biomarkers, which has been practice changing, the EGFR biomarker and other biomarkers that we of late have understood more about it. A liver-limited disease, which is nearly a third of the colorectal cancer on the left side. It is more rather from conversion to a curative intent. The spin-off advantage of having a quantifiable biomarker that you can track the resistance. Why not bevacizumab? And what are the critics of anti-EGFR overdoing by just looking at one particular trial? So coming to the initial trial or the major trial of anti-EGFR therapy, and we all know this, a 1,200 nearly patient number where cetuximab was used with or without follow-free. There was a very minuscule progression-free survival, but it was statistically significant. But what was analyzed was the KRAS genotype, and then we got Pfizer, and the mutated KRAS showed no benefit, but the wild-type KRAS, you can see the incremental benefit increasing in terms of PFS and the overall survival. So there was a lesson learned, and this is how science and oncology has progressed by small steps and not by leaps. So it is beyond EGFR, refining the target of anti-EGFR, and that is what we have learned for the past 5 years. That this was there rather when there was this trial of 5-FU and leucovorin modulation, that there was some hints early on that you would have left side definitely doing better biologically because of all the factors stated in the slide over here. There was this hint, but then as we studied further, it was later realized that yes, left side is biologically good, it is prognostically good. But also then we got retrospective analysis of some major trials, and we realized that yes, it is also predictive apart from being prognostic. This is the distribution of the biomarkers, and if you see the RAS wild type is still a very big chunk of nearly 40%. And if you look at the liver limited disease of colorectal cancer, it is definitely a major chunk what we see. These were the trial which made us learn when they were retrospectively analyzed that you need to change your practice by choosing the left side and the wild types. And this was published, and this was a big number for a retrospective analysis by collating all these trials. They all looked at the RAS wild type, and then they all had actually predefined the tumor site location. So that was a good data that we could eventually have in nearly 2,000 plus patients. And the forest plot analysis, all you can see is suggesting that in the overall survival is on the left of the unity and suggesting that chemotherapy and anti-EGFR is better, reflecting into overall survival eventually. Likewise, also the progression-free survival, the final crystal down the line you see is definitely on the left side of the unity. So also the response rates, this time on the right side, yes, the response rates were quite significantly more when you use chemotherapy and anti-EGFR in these subset of patients who were wild type on the left side. So liver limited disease is something very important when we are talking about the wild type mutations and the wild type scenario and the left side colon. So it is a major chunk of disease pattern which is just liver limited, and you are looking at conversion therapy over there, or you are looking at a curative intent over there. And in case of borderline resectable, you then look at conversion therapy. This is what has been the classical teaching. So uh, uh, going further on this, uh, you have this was
Piyush, can
adopted.
you
Yeah,
make it
sorry.
full screen?
Yeah, sorry.
Full
So
screen.
this was. Is that okay, sir? Yeah. So this was adopted as the practice guidelines. This was there, as we can see the arrows, that the molecular profile change the use of anti-EGFR therapy. And these were uh, a lot of trials showing that you see the overall response rate in the liver limited disease, which is of a real interest to the surgeon if he is looking at operating these lesions. So you see the delta over here, the incremental benefit provided by anti-EGFR therapy is typically so unique that there is a good response rates increment if you are adding this therapy to chemotherapy backbone. And so also it is, we all have learned, and in our tumor board meetings we know that it is not the resectable type of 1 to 3 sort of metastasis that you take up for conversion therapy. It is the borderline group that is important, and that is what we see that was clearly reflected. One of the trials, the SIRIM trial, where cetuximab and the chemotherapy backbone was used, 33% were the resectability rates, and these clearly reflected into the survival benefit. Well, if you have defined your biomarker so well, then you can have a spin-off advantage of using precise medicine, precision medicine. And it pays when you know your target very well. You can track the resistant mutations. And then these are the ways that the EGFR therapies can get meet their resistance. So it is either in the ectodomain mutations of the EGFR, or the downstream pathways like the MAP kinase pathways, or the RT receptor tyrosine kinase amplification as the HER2 gene amplification. So what about giving a drug holiday if you can actually measure by liquid biopsy that the RAS mutant is the subclone is actually going down? If you can track that subclone, and when you see that the subclone levels are going down, and then you can reintroduce. So that is what we learned. And apart from this, cetuximab in the first line elderly, you can consider omitting oxaliplatin also. And this, we have this ASCO, there is almost similar progression-free survival. Where is bevacizumab in the schema of things? I would say look at the delta, the previous slide I showed, and look at the delta over here. It's just not lifting the resectable rates, the overall response rates. So at this, I've just come to the my last point. You have one study, the new epoch study, which actually criticized this anti-EGFR. Now look at the schema again. You have chemotherapy, first of all, being given, the conversion therapy being given to resectable lesions. Why so? Why was it given at all at the first place to the resectable lesion? And then you follow it up with further chemotherapy after you resect those lesions. So this is not the way we usually practice. The URTC trial has clearly shown that you can actually wait and watch, because steatosis is a matter. So these points of concern were there. These small lesions actually disappeared from the liver. What would the surgeon do? These lesions were quite very well resectable, and they just disappeared. So this is what it is, that you are having a therapy which has a very well defined biomarker. Now we can exploit this biomarker. Bevacizumab, on the other hand, the challenge has always been the biomarker. This is what we have to realize, that we cannot quantify it. Neither we do it prior to the therapy, nor can we track the levels. So I would say that in real sense, cetuximab or panitumumab, the anti-EGFR therapies are the real targeted therapies. Thank you.
Thank you, Dr. Peush. Next, Dr. Biswajit Dubashi is going to talk about the debate for VEGF therapy. Dr. Biswajit.
Yes. Good morning. At the outset, I would like to thank Dr. Sandeep for giving this opportunity. And Peush, thank you for the presentation. And my friend has already acceded defeat because his presentation went on only on conversion therapy. So he knew that there was nothing to discuss on the metastatic disease. So he said that everything on conversion therapy. So let me discuss why VEGF is important and how anti-VEGF therapy should be given for patients on the left side also. So my schema of presentation will be options of treatment in brief, the identification of RAS mutation, which is the key to cetuximab therapy, the VEGF therapy, efficacy and adverse effects. And then we would look at some of those data head-to-head studies, the meta-analysis, and how to sequence regarding resistance. And one thing which we all should remember in this setting is the cost analysis and conclusion. So look at this slide. It's very important to understand what are our determinants of choice when we look at metastatic disease. And one important is RAS mutation. The other thing which we need to look at efficacy, toxicity, and don't forget the cost, which is the logistics. We have multiple therapies available in our armamentarium. And don't forget that immunotherapy is also coming up as first line in MSI high. This is a slide which just tells you that actually, if you look at multiple trials and the benefit over a non-specified colorectal malignancies, overall, there's no much difference between an angiogenic agent versus a KRAS mutation, versus an agent for KRAS wild type. Now you can look at the mutation. You can see that except for the pink and the dark blue, the rest all you need to give bevacizumab, and only a small subset on the right side, and probably around 28% on the left side probably will be the KRAS wild type, which will require an anti-EGFR therapy. We also should understand that it is not only the KRAS which is important for EGFR response, but there are other mutations which we should not forget. So one is the BRAF, and can you just see that if you actually miss an mutation, your outcomes are going to be as good as the best supportive care. So it is mandatory to understand that we need to get a right testing done for the success of an EGFR inhibitor. Look at this data on HER2 amplification, clearly says that your outcomes are very poor with EGFR targeted therapy if you have an HER2 amplification. Now forget about doing a RAS, all RAS testing. Now we also have to do an HER2 amplification testing to see whether it predicts. Now, again, look at BRAF mutation. Again, there is no advantage if BRAF mutation is present. So as Peush showed this slide and said that there's a large amount of patients still will be requiring EGFR inhibitors. My answer is C. Again, you need to lose out another 5% on the HER2 testing, another 9% on the BRAF testing. So the key to the identification of the RAS mutation is very important for the success of a cetuximab therapy. Look at this data. This data says that if you are doing a testing method, there is a possibility of test failure to happen in 1.4 and a misclassification occurring in 4.3%, which is almost up to 5%. Look at, even if you're doing an NGS, in fact, many of us don't even do an NGS. Even if you do an NGS, if you're using an in-house primer, you almost have a 5% chance of missing a RAS mutation. And in the study, almost 4% of these patients actually miss the RAS mutation. So imagine you're giving a drug and you're missing a 5% chance of RAS mutation. And these patients are actually going to do as good as your best supportive care. Next question is about sidedness. Does it matter for bevacizumab? Look at this data. Though this is a retrospective data from a Denmark study, in fact, this data was used for a microRNA study. And what does this data show? Look at this data. It says that all left-sided colon is not the same. The sigmoid colon and rectum, in fact, do better than the right-sided. We already have shown that the right-sided colon is much better with bevacizumab. And now you have a data saying that sigmoid colon and rectum is much better than the right-sided colon also. And next, coming on to the 3 trials which my friend discussed. Now there are 3 first-line data between bevacizumab and cetuximab. First is the CALGB study, then you have the FIRE3 study and PEAK study. Let's go one by one. So if you go by the FIRE3 study, we know that cetuximab versus bevacizumab, the backbone has been fall-free. And look at what was the primary endpoint. The primary endpoint was overall response rate, not PFS or OS. And it was not even powered for a PFS and OS. Look at the objective response between the 2 arms. There's no differences in the response rates. Now look at the survival curves. The RAS wild type population, PFS, absolutely bang on curves, no difference. Look at the OS. The curves separate very, very late. In fact, it separates more than 2 years after randomization. So what does FIRE3 mean? Primary endpoint was objective response, which no difference. PFS, not showing any advantage. OS showing some advantage, but it's only exploratory. Confidence intervals are wide. Why is there a difference in OS? Because of the effect of the second line. After bevacizumab, the second line EGFR was given only in 48% of the patients, in some of which only 27 actually received in second line and 21 in the third line. So but look at what happened in the cetuximab arm. Everybody received bevacizumab in the second line, and this could have been the reason why the curve started to separate. The next question is the infrequent use of bevacizumab beyond progression after fall-free and bevacizumab, which is only 11% in this study. We already have data to say that there are 2 randomized control trials to say that maintenance bevacizumab or beyond progression, bevacizumab should be given, and overall survival benefit is there of 2 months, which was not done in this study. The other point is, look at the patients who discontinued therapy. 15% of patients in the cetuximab discontinued therapy, whereas bevacizumab only 11% of the patients discontinued therapy due to toxicity. Fall-free versus FOLFOX, which is an ideal partner with bevacizumab. We all generally in practice give FOLFOX. In fact, there was a study which said that yes, FOLFOX are fall-free, which should be a backbone to a bevacizumab. This was from an ARIS study, and this study actually said that it did not matter which one would you want to use. But look at the points in this study. Analysis was dependent on accuracy and timely reporting of events by the investigator. It was retrospective collected data. Patients enrolled up to 4 months after initiation of treatment, and the inclusion of patients with early progression or death events which happened early were not captured. So do we still feel that FOLFOX and fall-free are the same? No. Let's go to the second study, which is the PEAK study, which was panitumumab and bevacizumab. And what does it show? Look at this data. There were 2 subsets. One was the exon 2 study only, and then extended RAS. When they looked at exon 2, look at the PFS, bang on. And on the extended, look at what happened on the extended study. There were differences. Look at what happened in the overall survival. In fact, the overall survival in the exon 2 was much more significant than on the other extended RAS. So what does it mean? It means that it is by chance, small numbers. Subsequent therapy was given only in 30 to 40% of the patient. The next study is on the CALGB study. This is the study which is powered. Look at the differences. Cetuximab and chemotherapy bang on overall survival, and the primary endpoint also was overall survival. Look at the response rates, median OS and PFS, bang on same. The meta-analysis. The meta-analysis showed 2 RCTs and 3 observational studies. What were the kinds of patients which included? Left-sided colon and rectum were only 1,000 patients. So very difficult to judge from this meta-analysis. The meta-analysis, the maximum difference was by 1 study, which was a retrospective data, which showed a 7 months difference. The rest all, again, the major randomized control trial, hardly any difference in the overall survival. So look at the outcomes from this. Though the meta-analysis said that the EGFR inhibitors might be slightly better, actually speaking, there was a heterogeneity in the data collected. How much was the benefit? The benefit was very, very limited. So the summary of the meta-analysis: heterogeneity in studies, the primary location of the tumor not very well studied. There's no PFS benefit, only OS benefit, that too marginally. Is this evidence good enough to recommend cetuximab over bevacizumab? What about cost effectiveness? This study clearly shows that if you use 8 weeks of therapy, bevacizumab, it costed $9,324 when compared to cetuximab, which is almost 3 times the cost, which is 2 times the cost. And look at the life years and the QALYs, which was benefited from bevacizumab and compared to cetuximab. Now, what happened in ESMO? Agreed that ESMO had a slightly lower score, but you see what was the problem? Problem was they looked only at the RAS wild type. We don't even have the data for the subtumor type in the bevacizumab. So it's very difficult to say the benefit from the ESMO data. The next one is, my friend said that the depth of response and early tumor shrinkage, which could benefit actually for conversion therapy. But my question is, look at that study from which this is a review article, which looks at the scientific importance of this early tumor response needs to be discussed critically. With exception of one trial, all data it comes from a retrospective analysis. Lack of uniform evaluation and definition in the studies. The optimal evaluation and cutoff values are not clearly defined. And we know that early tumor response and survival endpoints relate to post-randomization events, a bias which cannot be forgotten. And don't forget there is something called time to tumor growth, which people are looking at in bevacizumab, because it may not actually respond, but it is also important to know even if this tumor is stable, but the time to progression is delayed, that is more important in a patient who has a metastatic disease. And finally, look at a decision recommendation. If you actually use an VEGF, you could use double VEGF, then use an EGFR, then use regorafenib, and you have a longer and multiple options available if you in fact use an anti-VEGF yearly. So conclusions: 3 to 4% of your EGFR wild. Imagine you are failing by doing a test, and you are every time worried that they actually may not respond and they might progress and they might do as good as best supportive care. Additional mutations we need to test each time. And as Dr. Peush said that every month, every 2 months, every 3 months, we are worried that a new amplification and a new progression might occur. And we need to keep on testing multiple times to see if the EGFR inhibitors are going to fail. And what about the first line? Data is still very inconclusive, though we have randomized data. One strong data of the CalGB study, which has an overall survival as the primary endpoint, clearly shows there is no benefit of cetuximab over bevacizumab. What about the meta-analysis? Heterogeneity of studies, use of second-line therapy, and no PFS benefit, some OS benefit marginal, differential toxicity. In our country, where cost effectiveness is very important, generic bevacizumab for 1 month therapy is only 60,000 rupees when compared to 1.5 to 2 lakhs for cetuximab for a monthly therapy. So obviously, VEGF inhibitor is the clear winner here. Thank you.
Thank you, both Peush and Biswajit. Anything you would like to say, Peush?
Thank you again, sir. Dr. Biswajit sir said that, why I was talking about conversion so much all through. Well, we need to realize that this is the subset of patients where we are actually looking at liver-limited disease. And conversion therapy response rates are very important when we are looking liver-limited disease. We are looking at curative and the only curative intent. I'm talking, and I'm in for cetuximab when we are looking at conversion therapy only. I'm not talking about long-term, what Dr. Biswajit said, that, a lot of toxicities, you cannot give cetuximab for long. Another point Dr. Biswajit pointed out was that you are losing on patients because of some mutations coming up. BRAF mutation, well, there is some data on bemarituzumab, irinotecan, and cetuximab being used. So that probably, if you look at mutations, further mutations, you do have combinations further. Of course, I'm not talking about Beacon trial, which is down the line therapy. So, well, does HER2 testing, would you change your cetuximab partner because you are opting for conversion therapy? I don't think so. That would be the way, because we know that HER2 is one way that uh, HER2 new the receptor gets more as a pathway, comes up as a trouble when you're giving cetuximab rather than being as the upfront. It's quite akin to not giving TKI because your some T790 is being detected. So uh, but I would suggest that it is basically in the conversion therapy that cetuximab has definitely a big role to play, or panitumumab has a big role to play when we are looking at these patients with curative intent. Thank you.
Thank you. I think it is important, really, as you said, for conversion is probably one of the curative areas. So one should really strongly look at it. The general, yes, VEGF therapy may be helpful, especially with the cost. But of course, we all know all these are at the end a palliative and a prolongation of life. So those two have to be kept in mind. I think with